Welcome again to another episode of our Focus on Facebook. My name is Husnain Kermalli. I'm the Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Each month we like to bring you new insights on the different developments that are happening here and our opportunity to connect with the community. And this month is no different. I'm happy to introduce to you our new chairman in the emergency room, Dr. Mark Notash. Mark, thank you so much for joining us today.
Thank you for having me.
We're truly blessed here at St. Mary's Hospital. We underwent a transformation and brought on new partners and in fact the same providers, but a new group here to manage it. And Mark was part of that new group, having had a lot of experience outside of just the Waterbury market, and is able to bring a lot of that experience to bear here and up our game, so to speak, in the area. And we'll get into all of that. But first, we wanted to talk about you, Mark,
Sure.
and sort of your journey and what inspired you to get into the medical field. And so tell us a little bit more about your background and your journey into medicine.
Sure. Yeah, and it's interesting because we've known each other for a while now, but we've never had that conversation.
Yes, indeed.
So I grew up in a medical family. So my dad was a surgeon, trauma surgeon, and general surgeon. My mom was a nurse. They met in the hospital. So it's
Wow.
like that classic story, right?
Great.
And then most of my aunts and uncles on my dad's side were all in medicine as well.
Okay.
So you might think, oh, well, naturally, of course, that's why I'm here. And in some ways it is. But then the other side, my mom's side of the family, although she was a nurse, my grandfather was a carpenter, master carpenter and builder. And he actually, I grew up in Cleveland. He built, some big buildings there at the time and built part of the Hopkins International Airport. That area that he built's still there. I walk through it when I go visit sometimes. And he said something to me when I was young that, work smart, not hard. And in between college and medical school, I was working very hard. I was doing a lot of construction, kind of following in my grandfather's footsteps. And even my great-grandfather was also a master carpenter. And I was realizing that I should really think about what Grandpa said, and I did, and I said be good to work smarter, not harder. And so I decided to really push hard to get into medical school, and did that, and then of course I don't think it would have happened in a void. Maybe I would have gone into business or something if I didn't have that medical background on my dad's side. But so that's how I ended up going ahead and pursuing medicine. Of course, a lot of people thought I would never do it because I had a long gap between college and med school. But
some of us did as well.
I
think some of that gap allows us to get a little bit of world experience.
Absolutely.
And sometimes makes for a better clinical conversation with patients because we're able to relate.
Yeah.
Which comes with time, anyways.
Yes.
As clinicians move along, but sometimes it's nice to get a little bit of a break between schools.
Agreed. Yeah.
And then what about the transition to emergency medicine? So you were a carpenter.
Yeah.
Which may have led you down the pathway of orthopedics.
That's where I was headed.
Traditionally, I think is
that's
what
where I
people
was going.
say.
Yeah.
But then you took a turn.
Well, and you nailed it. I literally thought I'm going to go into orthopedics because I'm a carpenter. I may as well just keep doing that, but on the body. And I'd had some orthopedic injuries. I got some screws and plates in various parts of my body. I won't pull up all my pant legs or anything. But I did think that would be a natural transition for me. But then when I was rotating, third and fourth year, I just really clicked with the emergency medicine physicians. And also the team, the nurses and everybody in the ER and the environment. I felt like, wow, this is really a great place to be. And the surgery world, it was just different. It's not better, it's not worse, it's just different. Yeah. And I just felt like this is a better fit for me. And some say it's because it's good for people with ADHD. I don't know.
Well, I mean, you're dealing with. And we all remember the shows on TV, the ER show, of course, way back when, and today the big one everybody talks about is the Pit.
Right.
and of course Noah Wiley's in both of them.
Right.
But regardless of that, how do you manage that high stress environment, particularly after the past couple of years where there's been trauma across the board on many physicians who've had to deal with what happened within the emergency room? How do you deal with and how do you manage that, keep yourself calm in that high stress environment?
So, I mean, you're obviously dealing with a lot of things, in parallel processing and various stages, when you're dealing with, like, you've got 10, 15, 20 people that you're primarily responsible for at the same time. But at the end of it, it's really, you can only be truly in front of one patient at a time. And so you bring your presence to that patient, to the bedside, you take care of that patient, you deal with the team that you're, working with to take care of that patient in that moment. And then when whatever you've had to do for that patient is, in a steady state, you can go back to the other 15 or 20 people that you have, or the new 1 or 2 that you have to go deal with. And you just keep moving through.
It again embodies that concept that we continue to espouse and we want to promote here, which is patient-centeredness.
Right.
And keeping that patient in the center of what you're doing on a day-to-day basis continues to reinforce that. And hearing it from you, we haven't practiced this, so it's beautiful to hear that it's that same mentality that then allows you to maintain your cool, because you're focused just on that one person in front of you instead of everything that's going on in the emergency room. Yeah,
it can be overwhelming if you don't allow yourself to breathe.
Breathe.
Yeah. If you don't allow yourself to breathe while you're at the bedside, and you don't take the moment to recognize, I'm here with this patient right now, and I'm not with those other patients right now. They're in my mind. I've absolutely not forgotten about them.
Of course.
But and it's also to your point about, we didn't rehearse this, but it is important to have the patient-centeredness. Is like, for the patients or the family that's at the bedside, or even the team, the nurses and techs and everybody else, it's important for them to feel that you're there for that person at that time, and not have them feel that you're there for somebody else and you're not paying attention to what they really need. So
so let's clear up some misconceptions. What misconceptions? What do you think is one big misconception about the emergency rooms that you're like, well, let's fix this? We talked about the TV shows, and many people come up to me and they're like, well, is it like that? But from your perspective, a big misconception in the ED that you'd like to
I'm not going to run a CT scanner. I'm not going to go and do actual neurosurgery or cardiac transplant surgery as an ER doctor.
In the emergency room.
I'm not going to do all those things. So certainly, there's the work that we do, and there's the work that the other people in the hospital do. And so, a lot of the TV shows weave these misconceptions about how, especially the older ones, the ER show, like you said, the ER residents or doctors are doing everything. They're, and we, I was cleaning chairs down there today. I'll start an IV, I'll do this, I'll do that, but I wouldn't know how to run the CT scanner if you paid me.
Right.
You'd have to teach me. But and so there's a misconception that in the ER that the people down there are just doing all of the things, and of course it's the team. So and also that's another thing that and actually the show The Pit did a better job than some of these other shows, that it's demonstrating that it takes all these people in all these different roles to do the work of caring for the patients in the emergency department, just like it does in the hospital, as opposed to sensationalizing like me or the ER doctor doing everything. No, that's not real. Like we do our part, and the phlebotomy does their part, and the people who are in the lab do their part, and the people who the radiology folks do their part, and the nurses do their part, and everybody does their part. And housekeeping and EVS and registration. And it's like, if we don't have everybody there, security, we don't have everybody there, it doesn't work. You got to have everybody there. You got to have the physical plant working properly too, and the equipment, supplies, and all these kind of things to make it actually work.
No, it's a wonderful concept, and I think it proves itself true in day to day at the hospital. The team work concept and the team concept surrounding, again, that patient right in the middle. And when it's working well, as it does many times here at the hospital, it's a beautiful thing. It's a beautiful thing for the patient who ultimately gets the greatest care that they can. But it provides a lot of satisfaction for the team around. Because that horizontal hierarchy, as opposed to the vertical one that gets sensationalized, is something that's great in practice.
Yeah, absolutely.
So let's talk about now changes that have happened in the emergency room. Particularly after the pandemic. Big changes, or maybe even changes in the field of emergency medicine. Give us some insight on those.
Well, early on, both during and immediately after the pandemic, one big change was that nobody wanted to go into emergency medicine. So there was just, residencies were not filling, and we had prior to the pandemic, emergency medicine was, a very competitive residency program to get into, and we would routinely not match residents because there were too many people wanting spots. And then it became all of a sudden, who wants to be in the ER? I mean, the perception was this is a terrible place to be. You're in front of everything, and that's, I mean, not that it's a terrible place to be, but it's true that we're in front of everything. And anything that comes in, we got to deal with. So that we took a hit in the ER in our the perception of us took a big hit, and our reputation. And so in terms of within medicine, not necessarily in the public's eyes, that's a different issue. But and so then we've come back from that, and actually recently now we're back up to being competitive again.
Great.
And so that's encouraging to see. So now we're starting to get back to the place where we actually maybe are too full and don't have enough residency spots again, which is good. So so the workforce portion has changed, but we've also, the other piece of the workforce, again, because it's not just about the physicians, it's the team. Nursing has been hard to recruit across the country, not just here, or not here specifically, but and that is an issue. The pandemic really changed nursing, as you know more than anybody as the CMO. The issue with travel nurses, which travel nursing has been around forever. My mom was a travel nurse for years, and she loved to go do those travel gigs and make a lot of money, but it was different then than it is now. Now, so many nurses would just rather be travelers, even if they're really actually local. I experienced this a lot in Indiana and Illinois, that there were nurses who were really living in the area but were hired as travelers. And they were doing that so that they didn't get locked down to anything, and they could pick up and leave pretty quickly after their contracts, which meant that the charges that the hospital was seeing for the nursing hours, of course, is a lot higher per hour than it would be if you had a full-time nurse who would get potentially great benefits and everything else, but they're really a part of the team, they're a part of the family, they're beholden to the hospital and to the community. Whereas when you have the travelers, whether they are like, if you're in California and they're coming from Connecticut to go to California, which we saw a lot, or if you're, they're in Connecticut and the nurses are coming from California to work here, it's, there's no sense of ownership or pride of the hospital, the department, the community. You're going to go back to where you live later, and so that has, to some extent, degraded teams and team spirit at times in ERs across the country. And I think that's one, and even throughout the hospital, not just the ERs, but your question was about the ER. So that has definitely been something that has, I think, hit hard into the sort of the heart of the practice of emergency medicine, and that team spirit and the teamwork and the sense of belonging. And so, but again, I feel like we're turning a corner and we're getting back to, more of that, or less of the, providers that are doing travel nursing, and more of them that are coming back into the fold as like full-time or part-time local providers. And it's nice to be in that environment where you know everybody knows you, as opposed to somebody new every day that you don't know. So
well, and those are the two. I agree. I think you hit it on the head. Those seem to have been the biggest challenges. ER physicians and how they managed post-pandemic and the trauma that occurred there. Clearly, the reputation. You guys were the cowboys of the medical field. And then there was a period of time when it was like, well, who wants to be a cowboy and have to deal with wrangling horses all day long? I'd rather have something much more stable and do something that way. And now it's like, well, let's get back to wrangling horses. And you guys are jumping back onto that journey. But yeah, the nursing shortage, number one. The trauma that they went through, and then how it affects the emergency room, which again, we talked about that teamwork. And it's always easier to be a team as a family than to be a team as disjointed individuals. And so I'm glad that we here at St. Mary's Hospital, especially with our CNO, our Chief Nursing Officer, Shauna Edwards, and the work that the nursing director in the emergency room, Arla Washenko, and how they're working to make sure that that isn't the case in our emergency room. That we've really got a tight-knit family down there. I don't think we've got many travelers, if any, downstairs in the ED.
No, it's very nice.
It's all of us are, all of them downstairs are well connected and know everybody by first name basis, and you know where everybody's, kids are playing t-ball over the summer and all that stuff. Again, allows for that team to collaborate. And do you see that as a big improvement that we've seen the past couple of years here? Yeah,
absolutely. I mean, and to your point, when I first got here, because as you said, I'm new here, I was so impressed by the longevity of the nurses. I mean, people across the board, the providers, the physicians and nurse practitioners and PAs and everything. But when we did the whole round table thing and met everybody from the different departments and not just the emergency department, but the people, explaining if they've been here for, 10 years, 15 years, 20 years, 30 years, I mean, there were people here forever, They're part of the foundation of the hospital.
They were literally born here. They didn't start working right away, but they were born here.
And they brought back. Some of them did mention that. So, I mean, that is so impressive. And so, I mean, it's just helps so much to have that sense of community in a place where you're working. And then the same is true actually with the physicians. A lot of the physicians that are, that I've become a part of their team now, they constantly remind me, this is my community. This is my hospital. This is our community. And so that's huge, to have that. And not everywhere has that. So I think there's definitely something special here at St. Mary's that you have, that we have, that isn't the same all over the place, So.
And we're extremely fortunate to have developed that, and we're blessed that St. Mary's continues to be such an integral part of the fabric of the Waterbury community, and something that we're anticipating will continue for another 100 years as we move forward. Now tell us about the Vituity partnership. Tell us how we're doing there. Tell us about that adjustment.
Yeah, well, it's going great. As you mentioned, I came in from Vituity, and the majority of my career has been with Vituity. I started out in California after residency with what was known as CEP America, or CEP then, and then it transitioned to CEP America, and then later became Vituity. As we started to transition and grow outside of California, it didn't make sense to have that name anymore. So that's how long I had been a part of that, is from before it was even called Vituity. And I knew when I started that it was something special. I was skeptical. When I graduated residency, my attending said, be very leery of these groups, they'll chew you up and spit you out, or they don't care about this or that, or patients, they only care about money and these kind of things. And so I really went in with quite a bit of caution in my mind when I started. And I even kept my academic appointment at UC Davis, where I had done residency, and kept my appointment at Kaiser. And I thought, I'm ready to jump ship if this group is not, good. 6 months in, I was like, that's it, I'm done. I talked to Dr. Kirk, who was the guy who did the schedule at Davis. I said, do you need me anymore? He said, no. I said, okay, I'm done. Kaiser, I talked to them, and I said, okay, I'm all done. And I knew that I had found a group that was really special, that they, first of all, patient-centered care, like you said.
Correct.
So number one, it's all about improving lives. That's our core mission, is improving lives, as many lives as we can. Patient lives, of course, but the lives of the staff we work with, us, the physicians, the nurse practitioners, the PAs, the rest of the people around us, So,
you've improved my life.
Yeah. So, that's the idea, is improving lives. And then, I did a stint when I first started with them as a board liaison to the board of what was CEP back then. And I remember sitting there and hearing, what they were trying to, plan of, like, what do we want to have our group become in 5 years, 10 years. And they were focused on, again, patient care, and improving patients' lives. And then they said, but we also want to have fulfilling, rewarding career opportunities for the people who work with us, whether it's physicians or nurse practitioners or advanced providers, or the other people we employ that help us run our practice.
Yeah.
Or, we used to use a lot of scribes. We had our own internal scribe company. Improving all of these people's lives and making sure that people had fulfilling career opportunities. And I thought, this is really awesome that everyone's focused on that. They weren't talking about how do we get the best margin, and importantly, we're 100% physician owned.
Yeah.
We have no private equity. We have no debt. So we're beholden to ourselves and to the patients and to the hospital partners. Yeah. And, like you, the CMO and the CNO and the CFO of the hospitals and things, but we aren't beholden to investors on Wall Street. We aren't beholden to debt that we owe to whoever it is that we owe it to. Yeah. We have no debt. We have no investors. And each physician in the partnership owns the same share that every other physician owns. Like I own the same as the CEO and the president. So it's a great organization. And here, as far as the transition, I've been so excited to be a part of this transition and helping to steer the processes downstairs in the emergency department, because that's my bailiwick. That's where I kind of geek out, is like operations and improving efficiency. And today, as you know, we rolled out.
Today we rolled out a new process.
Yeah, new process, RME, Rapid Medical Evaluation, and I showed up at 6, and although I'm wearing scrubs, that's just because that's what we do in ER. We wear pajamas all day. Yeah. So, but I didn't come to work and see patients. I came to help guide the new process and make sure that things were going well and that people understood what they were to do. And we came in, and there was a large backlog of patients from the overnight, and so I did help. I saw a few patients to help with that, just only like 3 or 4 patients. And then my PA, Sarah Sullivan, did an amazing job, and she went through the rest of those patients in short order, probably within an hour. She had 10 of those people all taken care of, and then she stayed in the front for another hour and saw about 3 or 4 more people and got them started in their process. And then we transitioned out to a new provider. Dr. Kugler came on, and he started seeing people come through the door. And then he did that for 2 hours. And then Lila, one of our other advanced providers, came in, and she took over in the front office area and seeing people in triage. And what we saw was that where we typically at this hour would have 10, 15, 20, 30 people, and especially if we start with 10 or so in the waiting room at 6 a.m., it would probably be 30 people deep right now. And instead, we've seen 40, by the time I came up here a half hour ago, we'd seen 41 people from 6 a.m. until noon.
Sure.
And our time to provider was about 15 minutes. Wow. Our time to, that was time to room. Our time to provider was about 13 minutes. Our time to discharge was about 91 minutes. And for some ERs across the country, that might not even be impressive. But for us here, compared to what we're used to, that's very impressive. Yeah. And of those 41 people, we've already turned around and taken care of, treated, and gotten them on their way, about like 15 to 20 of them. Yeah. And we're working through the other, 20 or so, and taking care of them. And some of them have to be admitted, some of them still need more workups and things, and then we can figure out what to do. But we've treated people and got them on their way to wherever they need to go very quickly and efficiently. And so I'm super excited about that. And I took a picture of the waiting room I showed you. I don't think it would work if I held my phone up to the camera. But
the waiting room seems to be nice and quiet.
It was not bad right now, yeah. And normally at noon, it's a little bit of chaos.
A little bit chaos, yeah. So. Well, I mean, I love to hear that. I think that's been one of the pieces that continues to be feedback that we've gotten from the community. Mm-hmm. How are we going to get this improved? Mm-hmm. How are we going to get this improved? And it's beautiful to have heard and to work through a number of iterations. We've been trying. This definitely has proven to be, and it's early, so we're going to continue to work on it. Yep. But a definite adjustment in how we're going to manage it, really moving all providers through, getting patients seen, getting patients managed effectively, efficiently, and with the high quality that we all have come to accept and expect from St. Mary's team. So congratulations on that, and thank you for making that a reality. Yeah. And we're looking forward to sharing that with the entire community.
Yes,
so
absolutely.
Doors are open, and we got ED providers ready to go, and wait times that are better than urgent care, which is great.
Yeah.
So as we come to the end, one of the things that we like to do is ask you a question from the previous guest, who is our new chair of surgery. And so she's posed the question: what would you envision as the best way to strengthen interdepartmental ties so that we can develop sort of a medical neighborhood mindset at St. Mary's while keeping the patient at the center of these new ideas? So how do we develop sort of a medical neighborhood and develop better interdepartmental ties?
Ironically, I think that a lot of that has to do with how we interface with technology nowadays. Because, as you know, we recently came out, the hospital came out, Trinity did, with a new referral process. And when we're dealing with interdepartmental ties, communication is very important, and being able to communicate effectively across the specialties and different departments is key. So the new referral process allows for providers in the emergency department or upstairs in the hospital who are seeing people who are admitted and then discharging them to refer them to various specialties on their disposition, and having that communication go to those offices and not be lost somewhere in cyberspace is very important. Similarly, as you know, we've Dr. Monet Casey, my counterpart in the hospitalist medicine service, also with Vituity, she was carrying a pager, and she like any
a pager, the old pager,
pager, and like any doctor who's worn a pager,
that's right.
Everyone hates the pager. She hated the pager, and she said, we got to get rid of this pager. And so she said, well, how can we improve communication? Because it's not like I hate the pager and I don't want to get the calls. It's how can we improve the process? And she said, look, we have Epic capabilities. We have a chat function. Yeah. Let's use the chat. You can communicate in real time. You don't have to page somebody. Then, 9 times out of 10, as an ER doctor, you page somebody. You ask the unit secretary to page them. You're up seeing a trauma, and the person you page calls back. And then you're not even there. Yeah. So, if you Epic chat them, you can get them information about the patient. Connect the patient to the chat, and tell them, hey, this patient needs you because of this. And I'll extend this beyond Dr. Casey and the hospitalist team and say that I think the best way to get the interdepartmental processes working to really center around the patient and not what's going on with the unit secretary, where is the doctor at this point in time that I'm trying to reach from, this specialty or that specialty, but I'm just going to send that specialist or even a team, the hospitalist and the specialist. I'm going to Epic chat all of them with the patient's information attached and say, this is, Mr. Smith, and he needs a hospitalist, he needs an orthopedic surgeon, and oh, by the way, he needs a cardiologist because he's got bad heart disease, but he needs surgery for his leg, and we need to have the cardiologist see him and clear him, and the hospitalist needs to admit to manage this complex medical condition, and the orthopedic surgeon needs to take care of the fracture. Everybody has all the information in front of them. They can all communicate back and forth. No phone calls. Now, we still need the unit secretary, but point being is that's for other things. That's for transferring patients. Can you call the lab? Can you call radiology? Why is this not back? Can you get somebody to come pick up the blood, or find out why things are, there's a lot of work for them to do, but the communication piece can be improved if we utilize technology, and then that helps the patient ultimately. So I think that would be the way that I would think that we could do that, between the referral process and the communication between the teams and the physicians. And by the way, speaking of teams, you can loop in the nurses on those Epic chats too.
I mean, it's the greatest opportunity that we have, and I'm truly thankful that we continue to invest in those technologies that are going to allow us to improve the communication, so that we're not having to wait on a pager or return a call like we used to do years ago. So now we're going to ask you to do the same thing. We're going to ask you to ask a question to the next person who's sitting in your seat, so that they can sort of continue this conversation. So a question for them.
Okay. I guess I would say, as they think about their work throughout the hospital, I would first posit to them that the emergency department is generally the front door.
Yep.
And because of that, the front door needs to look pretty. It needs to be perceived in a good light, and and the door better open and close well. It better work, right? And so, without wanting to sound selfish, but what can that next person sitting in my chair do to help the way that the processes work in the emergency department? So if it's a transporter who's sitting here next time, how can they better help support the team in the ER to help throughput, help patient care, help us make sure that we do things as efficiently as possible, so that we can focus on providing the best care and the most compassionate care to each patient, as opposed to having to me run the patient upstairs. Or if it's a radiologist, for example, like how can they best support us? The hospitalist, whoever it is, a nurse up on the floor, all of the people that touch various parts and facets of our hospital have an integral role in improving the throughput and the patient care in the emergency department. So I would ask them, what could they do in their role without leaving where they work to help improve the processes in the emergency department?
I love it. We'll find out what they say. We'll find out what they say. One last request of you, and we like to end on this note, is for you to give a pearl to the audience, a clinical pearl that they can take home with them surrounding your clinical expertise.
Okay. About a patient I saw, or
no? About how they can improve their lives.
Oh, their lives. Okay.
From what you know.
Okay. Yeah. All right. Well, this may not sound exciting, but it's very, very true. And especially as a hospitalist dealing with patients who have a lot of chronic diseases who have to be admitted to the hospital. But we see the same thing in the emergency department. And I'll say that ending up in the emergency department or being admitted to the hospital or being unwell is something that a lot of us think is a result of something bad happening to us. And in some cases that's true. But I would propose that a lot of what causes us to end up in the emergency department or be admitted to the hospital is because of the things that we do to ourselves. Whether it be our diet, our lack of exercise, bad habits, smoking, drinking, other worse habits, if you can do something to help improve your overall well-being, whether it be those things I mentioned and choosing good, decisions as opposed to bad decisions, and you should do that. You should take care of yourself and look to your family and see how you can help them to take care of themselves instead of us as a society, living our lives in a way that is not healthy and then finding ourselves in the ER.
Yeah.
So.
I love that. It's that wellness focus to continue, and it borders on the preventative.
Yes, absolutely.
I think it's that mindset to say, hey, we love taking care of people, but we would rather them not see us than them see us.
Yeah.
And we're here for when those other things happen.
Yes.
But we would love it so that we don't have to see people if we can, and that prevention is a big piece of that. But that personal wellness is a great thing, and making the right choices all the way around.
Yeah.
So
absolutely.
Wonderful. Thank you again very much for joining us, Dr. Notash, and we look forward to seeing you all in the future on our next episode. Have a great day. Thank you.
Thanks.